Welcome to the deep dive. Let's jump right in. We're living longer, which is generally great news, right?
Absolutely.
But it does mean that, well, more of us as we age are likely going to need surgery at some point.
Yeah, it's the reality.
And surgery can be crucial. I mean, life-saving, definitely life-improving sometimes.
For sure.
But, you know, it's not without risks. And those risks, they can definitely be higher for older folks.
They can. And the thing is, it's often overlooked that older adults coming in for surgery, they usually have more going on than just the one issue needing the operation.
Right. A complex picture.
Exactly. Their overall health profile is often, well, complicated. And while we might instinctively think, okay, age, that's the main risk factor.
Yeah, seems obvious.
What the research keeps showing us pretty consistently is that something else is often, a much stronger predictor of how they'll actually recover.
Okay, let's get into that. You're talking about frailty.
Precisely. Frailty.
And this deep dive today, it's based specifically on some really important new clinical practice guidelines. These come from the American Society of Colon and Rectal Surgeons, ASCRS.
A major group.
Yeah. And they basically synthesized a huge amount of research on this very topic. How to evaluate and manage frailty in older adults having colorectal surgery.
That's right. These guidelines pull together the latest evidence, so our mission here really is to unpack them for you.
Distill the key takeaways.
Exactly. We want you to understand what frailty really means in this surgical context, why it's just so critical for outcomes, and importantly, what the recommended approaches are now.
The goal being?
The goal being to give older patients, especially those identified as frail, the absolute best shot at a good outcome. And, you know, that's not just about surviving the operation.
Right. It's about quality of life afterwards.
It's about truly living well afterward. That's the focus.
Okay, so let's dive into the core problem highlighted in these guidelines. Because the central finding, it's pretty striking.
It is.
Treatment recommendations, they argue, should really prioritize a patient's degree of frailty, like their physiological age, their resilience, rather than just their chronological age.
It's a big shift in thinking. Because for years, you know, studies used age, often with these, well, somewhat arbitrary cutoff, 65, 70, 75.
Standard practice, almost?
Kind of, but the evidence is getting clearer and clearer. The link between just your age and years and how you do after surgery, it's inconsistent. It really doesn't paint the whole picture.
Right, because frailty isn't just a number. It's more about having less reserve. Like your body's backup systems are low.
That's a great way to put it. Reduced reserve capacity across multiple body systems. So when a major stressor hits, and surgery is a major stressor, if that reserve isn't there, you're just much more vulnerable.
Vulnerable to complications, tougher recovery.
Exactly. And the guidelines often refer back to Fried's phenotypic definition. It's quite specific.
Okay, what does that involve?
It defines frailty based on having 3 or more of 5 specific things: slow walking speed, weak grip strength, low self-reported physical activity, unintentional weight loss, or just feeling exhausted much of the time.
And the data linking this frailty state to outcomes is strong.
Very strong. Frailty consistently predicts those adverse outcomes we worry about. Getting readmitted to the hospital, longer stays, needing to go to a nursing facility instead of home.
Serious complications too.
Yes, serious complications, and unfortunately, mortality as well. Studies using big databases like ACS and SQIP, or those involving comprehensive geriatric assessments, they show frailty predicts these issues more reliably than just age or even common scores like the ASA physical status.
So it's a more accurate red flag.
It seems to be. There's specific evidence, for instance, in older patients having cancer surgery, where frailty was linked to higher 6-month mortality, but their age or their ASA score actually wasn't.
Wow. Okay, so if frailty is this key vulnerability, identifying it early seems absolutely paramount. The guidelines really push for screening for frailty in the clinic before surgery. Is that practical? Clinics are busy places.
It is, and the guidelines emphasize that it is feasible. Now, the gold standard is the Comprehensive Geriatric Assessment, the CGA.
That sounds comprehensive.
It is. It's a deep dive physical, mental, psychosocial, functional health. But it does take time. The good news, though, is that there are shorter, quicker screening tools.
Ah, okay. Tools that work in a regular clinic visit.
Exactly. Tools that can flag those potentially vulnerable older adults effectively without taking up, an hour.
That makes sense.
Yeah.
Can you give some examples? What are these quicker tests?
Sure. A really good one is the timed up and go test the TE. Super simple.
Okay.
You just time how long it takes someone to stand up from a chair, walk 3 meters, turn around, walk back, and sit down again.
And that simple timing tells you something significant.
It can. Taking 20 seconds or more on the 2D, that's been shown to predict major complications, a longer hospital stay, and needing more specialist input during the hospital stay.
Interesting. What else?
Gait speed. Just how fast someone walks. Slower than about 0.8 to 1 meter per second can predict poor outcomes. Even just asking about recent falls.
Really? Just asking?
Yeah, more than one fall in the last 6 months. That's been linked to higher post-op complications and needing institutional care.
Simple but powerful indicators.
They can be. And then there are calculated frailty indices like the MFI or the RAI. These pull together data from different patient characteristics.
It's like a combined score.
Sort of, yeah. And they can predict things like length of stay, ICU needs, where the patient goes after discharge, even mortality, both short-term and longer-term.
And I noticed they also mentioned assessing sarcopenia. That's muscle loss, right?
Exactly. Loss of muscle mass and strength with age. You can actually quantify it. Sometimes using CT scans, they might already be getting.
Measuring muscle size.
Right. And finding sarcopenia, that correlates with worse outcomes too. Mortality, complications. It's another piece of the puzzle.
And for emergencies, quick assessments.
Yeah, they touched on tools like the FTRST. It's designed for rapid risk estimation in emergency settings, looks quickly at cognition, living situation, mobility, recent hospital stays, how many meds they're on.
Polypharmacy.
Right. To help gauge risk fast and inform those crucial decisions for the patient and family.
Okay, so beyond the physical aspect, strength, movement, the guidelines really zero in on cognitive function, assessing that before surgery.
This is hugely important and often missed.
Why is that?
Well, mild cognitive impairment, MCI, and even outright dementia are surprisingly common in older adults, even those living independently seeming fine.
Really? How common?
Depending on the age group, dementia can affect, up to 40% of older individuals, and MCI could be present in up to half of those over 65.
Wow, that's much higher than I would have guessed. And why is screening for that vulnerability so critical before an operation?
Because preoperative cognitive impairment is one of the absolute strongest predictors of developing postoperative delirium.
Ah, delirium. We hear a lot about that risk.
And screening for cognitive issues beforehand is strongly recommended because it lets the team anticipate that high risk. They can put preventative strategies in place right from the start.
Proactive prevention. What tools do they use for cognitive screening?
Some common ones are pretty quick. The Mini-Cog, for instance.
Mini-Cog.
Yeah, it involves recalling 3 words and drawing a clock face. Takes just a few minutes. A low score, like 2 or less, is linked to a significantly higher risk of post-op delirium.
Simple again, but informative.
Definitely. Another one is the SAGE, the self-administered gerocognitive examination. It can pick up MCI and early dementia.
Self-administered?
Yeah, patients can do it themselves, maybe in the waiting room or even at home before their appointment. There's even a digital version, which is great for tracking changes over time.
And spotting cognitive impairment before surgery, it's not just about predicting delirium, is it? It has other implications.
Absolutely. It signals, first off, that you might need to involve family members or designated surrogates more closely in the decision-making.
Making sure everyone understands the goals, the risks.
Exactly. Ensuring informed consent is truly informed. It also flags the need for potentially more support and closer monitoring after discharge, especially if there are memory issues.
Might need extra help at home.
Right. And getting a geriatrician or maybe a neuropsychologist involved early on can be really beneficial in these cases.
Okay. So screening tools help identify the risks, physical frailty, cognitive issues. What's next? The guidelines really emphasize optimizing these patients, a proactive team approach.
Yeah, and a key strategy here is something called prehabilitation.
Prehab. I've heard that term more lately. What is it exactly?
It's basically a structured program to boost the patient's health and resilience before the surgery happens, getting them in the best possible shape to handle the stress.
Preparing them for the hit, essentially.
Yeah.
What does that typically involve?
The core is usually exercise training, but it's often multimodal, meaning it includes other things too. Nutritional therapy is key, strategies to reduce anxiety, making sure other existing medical conditions are as stable as possible, maybe smoking cessation or cutting back on alcohol.
A whole package. And is there solid proof this prehab actually works? Does it make a difference?
Yes, the evidence is building. Meta-analyses, which pooled data from multiple studies, have shown prehabilitation can significantly lower overall complication rates,
Lower complications, like what kind?
particularly pulmonary lung complications and cardiac issues after major abdominal surgery.
How long does prehab usually take?
It varies in the studies, but often programs lasting around 4 to 6 weeks show clear benefits. Gives the body some time to adapt and build strength.
Makes sense. You mentioned exercise training. I saw a really interesting point in the sources about wearable tech, tracking steps before surgery.
Oh yeah, that study was fascinating. They used wearable activity trackers.
Like Fitbit?
Basically, yeah. And they found that patients who were more active, and they defined that as taking over 5,000 steps a day in the weeks leading up to colorectal surgery.
Okay.
They had significantly fewer complications overall and fewer serious complications compared to the less active patients.
So just being more active beforehand seems protective.
It strongly suggests that, yes, higher preoperative activity seems linked to a lower risk of postoperative problems. Now, you could argue maybe people who are already more active are just inherently less frail.
There's that possibility.
But it definitely highlights that connection between fitness before surgery and how well you recover after.
Nutrition seems like another critical piece you mentioned.
Absolutely vital. We know weight loss and poor nutritional status are big risk factors for worse outcomes in older surgical patients.
So boosting nutrition is key.
Crucial. Often involves working with a dietitian. And there's even some interesting research suggesting nutritional supplements might work together with exercise synergistically to improve energy and performance during prehab.
And the mental side, anxiety, depression.
Also critical, and maybe sometimes overlooked. Depression is more common as people age, and it is associated with worse surgical outcomes, higher rates of delirium too.
So managing that helps.
The guidelines cite studies showing that addressing anxiety and depression preoperatively, maybe through relaxation techniques or other support for cancer patients, for example, can improve their quality of life and reduce symptoms during that really stressful period.
Okay, so prehab gets patients optimized. But the guidelines also stress this team approach, bringing in expertise beyond the surgeon.
It's fundamental. This is where specialists like geriatricians really shine.
Geriatricians, doctors specializing in older adults.
Right. They have specific training in managing what we call geriatric syndromes, things like delirium, preventing falls, handling complex medication lists, polypharmacy.
Things that are common in older patients.
Exactly. And while they're maybe still underutilized in surgical settings, the studies show a massive impact when they are involved.
How so?
Well, there was one really compelling study. It found that having geriatric co-management was associated with less than half the 90-day death rate after cancer surgery compared to just the standard surgical care.
Wait, say that again. Less than half the death rate?
Yes, less than half. It's a genuinely striking statistic.
That's huge. What makes their input so valuable?
They're just incredibly skilled at spotting and managing those specific vulnerabilities, the subtle cognitive issues, the signs of frailty, optimizing complex medical problems, things a busy surgeon might not catch or have the time to delve into.
They bring that specific lens.
Precisely. Another study looked specifically at older colorectal surgery patients. It found that a multidisciplinary team approach, guided by a CGA, led to significantly fewer geriatric-specific complications, delirium, other syndromes, even though the patients in that group were actually sicker to start with.
So better outcomes even in higher-risk patients.
And pooled data from lots of studies confirms it. When geriatricians are involved in the hospital care, you tend to see shorter hospital stays, lower mortality, fewer readmissions. It's why initiatives like the ACS Geriatric Surgery Verification Program are emerging. They underscore just how vital this team approach is.
And I saw a mention of assessing social vulnerabilities too. Social frailty. What's that about?
Yeah, that's an emerging concept, social frailty. It basically means being at risk of losing the social connections and resources you need to meet basic social needs.
Like isolation, lack of support.
Kind of, yeah. Risk factors include older age, lower education levels.
And how does that connect to recovering from surgery?
Because recovery from major surgery is tough, right? Especially for older adults. They often rely heavily on their social network, family, friends, community support.
For practical help, rides, meals, medication reminders.
Exactly. Practical help, emotional support, just having someone check in. Studies show that having stronger social integration and support is linked to better functional outcomes after surgery, better health-related quality of life. Practical social support can even make a real difference in helping frail older adults actually stick with positive health changes, like exercise or diet, once they're back home.
Makes total sense. Okay, so we've assessed, optimized with the team, prehab, considered social factors. What about the actual surgery and immediate post-op period? How is that tailored?
Well, the guidelines talk quite a bit about enhanced recovery protocols, or ERPs.
ERPs, those standardized pathways.
Right. They aim to optimize recovery through things like patient education up front, specific ways of managing fluids and feeding, using multiple types of pain relief to cut down on opioids, and getting patients moving early mobilization.
Yeah, ERPs are pretty common now, but the guidelines say they need tweaking for older, frail patients.
Critically important point, yes. The core principles, get moving, get eating, are good for everyone, including older adults. But the specifics often need adaptation based on their individual health issues.
Like what?
Like fluid management. It needs really careful handling if someone has heart failure or kidney problems. Or when to take out a urinary catheter might differ if there are prostate issues. And crucially, medication management.
Being careful with drugs.
Absolutely essential. Avoiding or minimizing drugs known to cause problems in older adults. Resources like the ASCRS criteria list medications to be cautious with. Studies show older adults do benefit from ERPs, but they need that careful, individualized tailoring.
Got it. What about the surgical technique? Minimally invasive versus open.
The guidelines strongly lean towards considering minimally invasive approaches, laparoscopic or robotic surgery for frail older adults having colorectal surgery whenever it's feasible and appropriate.
And the thinking there is.
Because the evidence shows these techniques are safe and beneficial for older patients, even the very elderly, over 85.
What kind of benefit?
Pooled analyses consistently show advantages over traditional open surgery. Shorter hospital stays, faster return of bowel function, lower rates of common complications like pneumonia, wound infections, and ileus, that sluggish bowel problem.
And that shorter hospital stay, that seems especially important for older people.
It really is. Getting out of the hospital sooner means they can get back to their own environment, which helps maintain mobility, preserve their functional status. These are huge goals for older adults.
Less time being inactive in a hospital bed.
Exactly. Now, we always have to acknowledge potential selection bias in retrospective studies. Maybe surgeons chose less frail patients for minimally invasive techniques sometimes.
Sure.
But overall, the weight of the evidence strongly points to benefits when it's the right choice for the patient.
Okay, let's spend a moment on a really major post-op risk you mentioned earlier. Delirium. The guidelines give this specific attention.
They do, because it's such a significant issue. Postoperative delirium is incredibly common. It can affect up to half of older adults after surgery.
50%. That's staggering.
It is. And what's worse, it's often missed by the healthcare team.
So what exactly is delirium? What should people look for?
It's an acute, sudden change in mental status. The absolute hallmarks are fluctuating in attention. Their ability to focus just comes and goes along with changes in their level of awareness or disorganized thinking.
And the consequences.
They can be severe and long-lasting. Delirium can lead to permanent functional decline, cognitive decline, higher rates of other complications, higher mortality, a greater chance of needing nursing home placement, and it drives up healthcare costs. Plus, sometimes delirium is the first sign that another complication, like an infection, is brewing.
So it's a serious warning signal. How do clinicians screen for it?
Standardized tools are used, like the Confusion Assessment Method, or CAM. It looks for those key features: the acute onset, the inattention, disorganized thinking, or an altered level of consciousness.
And here's a critical question. Can it be prevented?
Encouragingly, yes. A significant portion of delirium cases studies suggest up to 50% are potentially preventable.
Half. How? What are the key prevention strategies?
It's usually a bundle of non-drug interventions. Multimodal, non-pharmacologic strategies are key.
Like what kind of things?
Things like keeping the patient-oriented clocks, calendars, reminding them where they are, who people are, promoting good sleep, minimizing noise and light at night, getting them mobilized out of bed, walking as early and safely as possible, making sure their glasses and hearing aids are actually being used and working properly.
Simple things, but maybe easily overlooked.
They can be. And then again, medication review is absolutely vital, avoiding or minimizing those high-risk drugs.
The ones that can trigger delirium.
Exactly. Again, referring to things like the Beers criteria helps identify culprits. Certain painkillers like opioids, sedatives like benzodiazepines, and drugs with anticholinergic side effects need very careful use or avoidance if possible.
And who is most at risk? Does it tie back to the vulnerabilities we discussed?
It absolutely does. The strongest known predictors for developing delirium are a personal history of having had delirium before, underlying frailty, and that preoperative cognitive impairment we talked about screening for. Knowing those risk factors helps target the prevention efforts where they're needed most.
Okay, all this focus on assessment, optimization, careful management. It feels like it leads to the most fundamental point, the most patient-centered one.
Yeah.
How do we actually define success for these patients?
This is so critical. The guidelines really push for this.
Moving beyond just clinical metrics.
Yes. For frail, older adults facing major surgery, having explicit early conversations about their goals of care is absolutely essential.
Goals of care conversations.
These need to happen early, involve the patient, their family or caregivers if appropriate, and the whole multidisciplinary team. And they cover. Well, yes, anticipated longevity might be part of it, but maybe even more importantly, what's their desired functional status? How important is independence to them? What about comfort?
So it's shifting the focus. Not just can we cure the disease, but how will this treatment impact the life you want to live?
Precisely. Numerous studies and surveys show that for many frail older adults, maintaining their ability to function, to live independently, is valued just as highly, sometimes more highly, than simply living longer or getting rid of the disease at any cost.
That's a profound perspective.
It is, and treatment decisions need to reflect that. We need to present a realistic picture of potential outcomes for each option, including the risks to their function and cognition. These are tough conversations, no doubt, especially in emergencies.
Which is why having them early is better.
Exactly. When there's time to think, to discuss, before things become urgent.
And if those are the goals, you're saying our measures of success need to evolve too. That maybe length of stay or time to first bowel movement, while clinically relevant, aren't the whole story for these patients.
They probably aren't the whole story, no. They don't fully capture what matters most to an older, frail individual. The guidelines really advocate for incorporating patient-centered outcomes.
Like what?
Functional recovery metrics become really important. Can the patient regain independence in their activities of daily living, bathing, dressing, eating? Can they walk safely again? Using tools like the ADL scale, maybe redoing a Mini-Cog assessment, or repeating the TU test or a 6-minute walk test can track this.
Measuring function directly.
Yes.
Yeah.
There was one study highlighted showing that functional decline, defined as needing more help with daily activities after surgery, was a significant negative outcome in itself, even if the patient didn't have any traditional surgical complications like infection.
Just losing function was a bad outcome.
A very meaningful one for the patient. And then there are patient-reported outcomes, PROs.
PROs, getting the patient's own perspective.
Exactly. How do they feel about their quality of life, their symptoms, pain, fatigue, even things like loneliness? Capturing their subjective experience, often using validated questionnaires.
And this is where the sources had that really surprising finding.
Yes, it was quite striking. A randomized controlled trial looking at cancer patients' median age was 61, so not exclusively older, but relevant, found something remarkable.
What was it?
Simply monitoring their patient-reported outcomes weekly via electronic surveys and alerting the clinical team when symptoms reached a certain threshold. Just doing that actually improved their overall survival.
Wait, improved survival just by tracking and responding to how patients said they felt?
Correct. Compared to the group getting standard care without that regular PRO monitoring, it strongly suggests that actively listening to and then acting on patient-reported issues isn't just about symptom management or feeling better.
It can actually extend life.
The evidence from that trial points that way. It really underscores that the patient's voice, their reported experience, is far more than just a nice-to-have. It can have profound impacts on outcomes we used to think were purely driven by clinical interventions.
Wow. That's a powerful thought to process.
It really shifts the perspective on what constitutes effective care, doesn't it?
It absolutely does. So if we try to pull all these threads together, caring for older adults who need major surgery like colorectal procedures, it really demands looking far beyond just their birthday.
Miles beyond.
It means zeroing in on their actual physiological resilience, their frailty, using broader assessment tools that capture function, cognition, social factors, bringing in that multidisciplinary team, especially geriatric expertise, implementing proactive strategies like prehabilitation,
getting them ready,
tailoring the surgical approach, adapting post-op care like ERPs, being incredibly vigilant about preventing and managing risks like delirium.
Vigilance is key.
And maybe most fundamentally, aligning the entire treatment plan with what the patient values most, their independence, their function, their quality of life, and then measuring our success based on those outcomes.
It's really a move away from any kind of one-size-fits-all medicine towards deeply personalized care, recognizing the unique package of needs, strengths, vulnerabilities, and priorities that each individual older patient brings.
Which leaves us, and you listening, with a final thought to really mull over, building on that incredible PRO study finding. If truly prioritizing and actively responding to what patients tell us matters most, things like maintaining independence or managing symptoms can not only enhance their quality of life, but potentially even extend their survival, well, what would a healthcare system that was genuinely built around patient-reported values actually look like? And maybe more importantly, how far are we really from creating it?